All right. Welcome to On the Sideline. I'm your host, Jeff Holden. Today we're here with Big O.
What's good? How y'all doing today?
And we have special guest from United Regional, Dr. Brad Dosher.
Hey, nice to meet you guys. Thanks for having me here.
Yes, sir. So, again, we're continuing our little mini-series, I guess you could call, with United Regional, being a very important sponsor for us, and then working in the interviews with Mr. Jeremy over there, but also with you and multiple others to come. But we do appreciate you coming here, taking time out of your day to talk with us a little bit and just talk sports and talk your specialty, your profession. You know, we understand that you're a orthopedic surgeon. I mean, a surgeon, not a surgeon, but orthopedic surgeon, rather. Reading your bio, you have a long history of dealing with sports and professional athletes and all that, which is really cool. I think that's really cool. But we just want to have you just introduce yourself real quick. I know you specialize in shoulders, but you do a little bit of everything. If you want to just give a brief introduction.
Yeah, absolutely. So I'm from Amarillo originally, went to undergrad and medical school at Texas Tech. So Big Red Raider, finally having a good season for once. It's nice to see. Throughout my entire kind of high school time, and even growing up, I played a lot of sports, was always kind of interested in it. I have the same story that I'm pretty sure every sports medicine surgeon has, in that I injured my knee whenever I was in high school, had ACL reconstruction surgery, kind of was interested in it, went into undergrad thinking maybe I want to be an orthopedic surgeon someday when I grow up. Was fortunate to work with a surgeon in my hometown of Amarillo who worked with West Texas A&M at the time and a bunch of the high schools. So kind of got to see the sports medicine side of it, was really interested in it, decided to do my residency in orthopedic surgery at UT Houston. While I was down there, really trauma heavy, but also worked with some really great sports surgeons. Dr. Walt Lowe's down there, works with the Texans. Dr. Flores, who does a lot with the Rockets, and then Dr. Fullick, who's really one of my mentors whenever it comes to shoulder surgery. Just really kind of made me fall in love with the different levels of sports medicine. It's kind of fun to see the sideline coverage of the Texans, working with the Astros, working with the Rockets, working with University of Houston, all the way down to really my first kind of on my own experience was covering some of the high schools down there. Actually covered North Shore in Houston, which has won a few state championships. They're a really good football program. It's really the first experience I had of, all right, here's your team, you're on the sideline, work with these guys. So it was an awesome experience. Wanted to learn a little bit more and kind of keep that going. So the 5 years of orthopedics is a little bit of all things: broken bones, spine, shoulders, knees, hips, hands, foot, and ankle. So kind of the full spectrum. Wanted to do a little bit more just sports medicine and just shoulders. So did a fellowship at Vanderbilt University in Nashville, where I worked a lot with Vanderbilt athletics. They did not have such a good football season. I was there for their infamous winless season in 2020, so that was a fun experience.
Oh, wow.
But while I was there, also worked with a bunch of the high school students there, as well as working with the Nashville Predators and the Nashville Soccer Club. So got to work, same thing, kind of pro, collegiate, worked a lot with the high schools there. It was really enjoyable to work with the athletes of kind of different levels and kind of different aspirations of what they want to do with life. Is sports everything for them, or is sports just what they're doing to get through college, or is it just something for fun for them in high school? When I finished that up, went back to Amarillo for a little bit, was the medical director at West Texas A&M in Eastern New Mexico. Was there for about a year and a half, and then got recruited to help start up and kind of build the orthopedic sports department in a hospital just outside of Myrtle Beach. Spent a year out there. Beautiful area, but I miss Texas. From Texas, my family's in Amarillo. Whenever I had the opportunity to come back, I was very fortunate that United Regional was looking for an orthopedic surgeon, especially somebody with sports training, and the match for what I wanted to do with my career and what they were looking for was perfect. So I've been here just for a couple of months now and really loved Wichita Falls. People have been awesome. The hospital system has been great. All the coaching staffs that I've worked with Midwestern, as well as Legacy and Memorial, they have great coaching staffs. The training staffs here have been really amazing. So it's been a very smooth transition.
Yeah, wow. So two things real quick. Coming to Wichita Falls, no professional athletes. Sorry. Not yet anyways. They're in training, right? And then second thing, how short is Jose Altuve?
Just as short as you would think. He is in person even smaller, honestly.
That's why.
And it is impressive to be in the dugout and watch somebody that size just murder the baseball. It's impressive. I mean, you watch it on TV and you get an idea, but when you watch that, it's impressive.
I imagine.
So a question that I would have for you, just because of all of the vast sports that you've covered, and this, you can just be honest. Nobody's gonna get you for being honest. What would be the sport? Would be probably the most interesting sport? Would you say? Of course, no sport is interesting for anybody to be hurt, but what sport would you say that's probably the most interesting that you've had to deal with when dealing with injuries?
I've worked with pretty much every sport at this point. I would say the sport I enjoy the most, which is weird for a Texan, was hockey. I loved working with the Nashville Predators. You don't realize the speed that those guys are going on skates until you're there watching it live, and it is terrifying. And the speed, the finesse, and it's a violent game. And also just the athletes. Working with pro athletes, they all have their own different culture. They all have their different personalities, but there's not really more of a team sport in existence than hockey. I mean, those guys, it's never I or me unless they messed up. It's we and us. So it's just a really fun group to be around. The surgeon I worked with when I worked with him was Jed Kuhn. It's probably the most influential in kind of the way that I treat shoulders and treat a lot of the athletes. And so working with him was really great. It's kind of a unique, weird sport that the professional level of coverage is really fun when you're in training. It's fun to get that experience. It's not something I wanted for my personal life, because whenever you're the team doc for the Texans or for the Predators, that's your entire existence. You're on call 24/7, 365. One of those guys stubs their toe, you're getting a call at 2 o'clock in the morning on a Saturday. And I have a lot of respect for the guys that do that, and they love it, and it's a really rewarding experience. So I'm glad I got that in training so I could experience it. But I really prefer kind of collegiate high school athletes working with on a daily basis. It's a lot easier patient population.
For sure.
I hate to be the dentist for those hockey teams.
Man.
They don't really do a lot during the season because they know they can't really do anything until the end of the season. So
that's true. What are some of the most common seen injuries? I guess they start really high school and collegiate, but pros too. But what are some of the most common injuries?
So for the high school collegiate shoulders, probably the most common that you see is injuries to the AC joint, like we talked about before we came on the air. And it's one of those joints that there's not really much you can do to prevent an injury to it. It's kind of the AC joint. People talk about their shoulder being separated. That's the AC joint up top here.
So for the nerds, what does AC stand for? Because
acromioclavicular. So you have the acromion, kind of the hard bone on the end of the shoulder. The clavicle is the fancy name for the collarbone. And there's a little joint there where the joints, it's not like a normal bending joint. It just kind of, they rub back and forth. And that joint, whenever you land and hit directly on your shoulder, is the one that usually takes the brunt of that force. So you see it a lot in football players. You can see it a lot in soccer players. Really any sport where you're getting driven to the ground and hit hard, you have AC joint issues. And there's a wide spectrum of, you can hit it kind of soft. And my guess is anybody that's played any sport has had some AC joint injury of, it kind of hurts if I bring my shoulder up, all the way up to those ligaments can completely tear and you have a shoulder that's kind of sticking out, and it will freak out some family members and some kids when they look down and it looks like their shoulder is completely dislocated. So that's probably the most common that we see in that wide spectrum. The good thing is most of them are non-operative. The downside is they're pretty annoying to deal with as far as the the recovery process. Other really common things that we see, injuries to the actual shoulder joint itself. So shoulder dislocations are a really common injury. That's when the ball kind of comes out of the socket joint. The shoulder is a little bit of a unique joint. Whenever you think of the hip, it's a really deep socket with a ball, and the bone gives you most of the stability. It's a pretty difficult thing to dislocate a hip. You can do it, but it's tough. The shoulder, it's more like kind of like a saucer with a ball sitting in it. And the only thing that really keeps it from dislocating is a layer of tissue that goes around the labrum. And oftentimes when the shoulder dislocates, it hits that labrum, comes back in, and that's why a lot of the shoulders, you kind of see them rehab a little bit longer. Sometimes they need surgery. It's kind of a philosophical debate on how quickly to do surgery on those, but that's a really common one with shoulder dislocations. The other thing I see a lot of in overhead athletes, so this time of year you see it in volleyball players, especially outside hitters. You see it a decent amount in tennis players, and then you'll occasionally see it in quarterbacks, is just a decreased range of motion. So the fancy term for it is GIRD, G-I-R-D, Glenohumeral internal rotation deficiency, which is a fancy way of saying they can't bend their arm all the way down. It's an injury that we see the most in baseball and softball players, especially pitchers. The reason you see it is for explosive overhead things. So think about whenever you see a slow motion of a quarterback throwing a football. Their arm looks like it's going to dislocate. It's so far back and crazy. The way that they get a lot of their strength and power is how far back they can go. That's external rotation, bringing the arm back. And so for them to have that extra motion, they lose a little bit coming in. So the arc should be the same. So if you gain 10 degrees going back, it's normal to lose 10 degrees going in. That's just the way that your body reacts to it. What we see and what you see a lot in baseball players, especially younger baseball players, is they get 20 degrees extra going back this way and then lose 40 degrees coming in. So it changes the mechanics of the shoulder. It causes a lot of just kind of this vague, it hurts after I throw. You'll see it in quarterbacks. This time of year, you see it a lot in volleyball players. Just anybody that's doing a lot of explosive coming back over their head. So that's a really common one that has thankfully gotten a little bit better now that athletic trainers and coaches have a better understanding of doing rehab and prehab for these kids. You always see the guys out in the bullpen with all the rubber bands and everything doing shoulder rehab stuff. Those are probably the most common. Also, football season specific, a lot of clavicle fractures, so collarbone fractures. Same thing as the AC joint. Sometimes when you go down and get hit, it hurts the AC joint. Sometimes it just shatters the collarbone. That's a really common football injury that I've seen quite a few of.
I think that injury is what caused the Cowboys the Super Bowl.
I was about to say that, but whenever he was doing the arm movement, I cannot think of the name of the movie, but it made me think about the movie. Is it called The Rookie, where the kid was the pitcher, and he just kept y'all know what movie I'm talking about?
I know what you're talking about.
The one with his arm, and once they finally got his arm to work, he was throwing 100 miles per hour or whatever. But speaking
I don't watch cartoons.
Oh man, come on! This was a real movie. I gotta look up the name of it. So my question is: I know you're a Texas Tech fan. I'm kind of give you the little weird questions. So OU, how was it possible? And not saying that it's everybody can do this. That Adrian Peterson that year that he broke his collarbone. How was he able to stomach? Because I just can't imagine somebody being able to play through an injury like that. But I know he played 3 or 4 games and closed out the season with a broken collarbone. So not saying that that's something that's recommended. I wouldn't recommend. I know you wouldn't. But how was he able to do that and get clearance to be able to do that? Like, was it like was it probably a partial, or like you're the expert. Because I'm still trying to understand how was he able to do that.
I think the first thing is to understand he's a freak athlete that also came back from an ACL faster than anybody ever has. With clavicle fractures, it really depends. I have no idea what his x-rays look like. If you have a small crack through it or it's just kind of a little bit broken, sometimes you're able to get back a little bit sooner. The ones where you completely snap the clavicle in half and it fully displaces, there's, I wouldn't say a debate, but there's definitely some gray area of do they get surgery or do they not get surgery? When I was in Houston, you can't ever really talk about a patient you treated if it's just you and them that know it, but whenever it gets reported on ESPN, we had a wide receiver that had a clavicle fracture. It was reported by ESPN he's going to be out for 2-3 months. He underwent surgery, and then the ESPN headline was really quickly like, Will Fuller's back playing in like 3 weeks. And so at high-level athletes, there is that discussion of getting them back in, doing that surgery, knowing that they're a little bit higher risk. The way that you fix it's a little bit different. Whenever I fix high school, collegiate players, professional collarbones, clavicle fractures, the way I fix it's a little bit different than just the average shoulder. Instead of putting 1 plate on, you put 2. It gives a little bit more strength. It also decreases the risk of having to take the plate out. But it's a very different mindset. And this is sports medicine. There's a lot of kind of the art of medicine. So the things that I would allow a 22, 23, 24-year-old college athlete going pro or a pro athlete to do versus a high schooler is way different. And the way I always tell them this is, take collarbone, for instance. If I have a high schooler that's 17 that breaks their collarbone, realistically, that's going to take about 8 weeks to heal. So for them, I don't really give them much of an option because I want them to have a normal shoulder for the rest of their life. And at high school and even really the college level, the goal is for them to have a normal shoulder for the rest of their life. For guys that are playing professional, playing a game or not playing a game can be the difference in tens, hundreds, thousands of dollars. It's a huge difference for them. So for them, having that sit-down discussion with their family, with them, oftentimes the agent, saying, we can try to go back. You're at a higher risk. You can get hit and you can break around the clavicle, and it can be a disaster. For them, I kind of let them make a little bit more of an informed decision of, here are the risks. You're a grown adult. You know what they are. So for them, I kind of let them make a little bit more. Same thing for some of the collegiate athletes. There are certain injuries that I will let them play with that are more minor, knowing that, hey, this could get worse. You're an adult. I'll let you make that decision. Is very different than the 14-year-old that is convinced they're going to play professional football, but at the end of the day, they're still a 14-year-old. And as a physician, I kind of feel my obligation is to protect them and make sure that they have a good shoulder, whether it's playing sports or if they just want to have a normal shoulder when they're in their 20s. So it's a very different mindset.
So I like that. If you don't mind, if I can nickname you Dr. BD, I like that.
Works for me.
I think that'll be a cool name for you because, you're very educated, but the part that I think I like the most as we're interviewing is just your passion of knowing the different levels of your expertise because, like you said, when you're dealing with a pro, it's a little bit different. You're dealing with not only just decisions that he's making, but the livelihood of financial things. But then when you're dealing with these high school kids, they have such a bigger future. And I think as parents, me being a parent of a kid that plays sports, sometimes it's hard to hear the doctor say, no, we got a few more weeks. No, we got a few more weeks. But I would say on the air, I think as a parent, I appreciate a doctor that's willing to look out. Because sometimes as parents, we're looking out for our kids' best interest, but sometimes we get caught up into the hype, and the different things. So it to me, it takes a great physician like you and what United Regionals is doing, especially hiring you as a person that cares about the interests of the kids. So I appreciate that because just hearing you say like, this is how I treat my high school kids. There's levels to it. To me, that shows that you're doing it for the right reason and not just doing it, but you're doing it for the right reason. So I appreciate you for that. I had to say that while I was thinking about it.
Thank you. I appreciate that.
The
other part I kind of want to say is, Jeremy's in the room, so we'll pretend he's not, but it's also the athletic trainers. Whenever they see a physician, we see them at best maybe 20, 30 minutes. It's a very short amount of time. You kind of talk to the family, you talk to the kid. Really, the people that get these kids back and that get them from me saying, okay, yeah, we'll go back to sports at some point, to actually making it happen is the training staff. And I think a lot of athletic trainers are kind of, I would say it's the most overworked, underappreciated profession that there is,
sure.
because those guys and girls work a lot of hours, way more hours than any physician ever does. They're with them on the sideline when they get hurt. They're with them in the training room. So that's a really big part of it that I think gets overlooked. We kind of the physician gets all the credit when things go well, but I always tell patients the easiest thing that you're going to do is me do surgery on you. The hard part's the recovery and having the training staff, and they have that relationship with the kids, usually with the parents, and certainly with the training staff, with the coaching staff. So that's a really big part of that puzzle that I think often gets overlooked.
Yes, sir.
At Orthopedics Express, our primary focus is delivering exceptional care to patients with orthopedic injuries, such as sprains, strains, broken bones, and joint pain. You'll receive the expert care you need when you need it most. Simply walk in or schedule an appointment through MyChart. Located inside the Center for Advanced Orthopedics, Orthopedics Express is your fast track to orthopedic care.
You went over probably your most common injuries that you see. What are some things that athletes or that programs that maybe you would encourage different ways to prevent an injury versus, I guess doing versus not doing? But what are some injury prevention that you would, I guess, encourage athletes and programs to maybe start doing?
So with the shoulder especially, there's been some published things out there that actually have good outcomes. Everything in medicine, we're kind of moving towards evidence-based, which means to say like, oh, I think this does really well because I've had 10 kids do well. Well, that doesn't really transfer to the entire country. There's now a lot of research on kind of how do we prevent this at young athletes all the way up to just kind of weekend warrior athletes. And there's some different exercise programs out there. One of the more famous ones that's been published is the Oslo Sports Trauma. It's a shoulder rehab, kind of prehab type thing. There's also FIFA did a thing where they had a bunch of goalkeepers having shoulder issues. And so they kind of have a shoulder prehab. And so you just kind of get online and look up that Oslo Sports Trauma shoulder injury prevention. I think it's like the FIFA 11 plus shoulder. They're all very similar. And it's most training staffs now are pretty good at kind of understanding the ways to prevent it is making sure you're keeping your motion. So we talked about the common injury of that they lose that internal rotation. The treatment for that's really simple. There's what we call a sleeper stretch where you lay on your side, you have your arm out to the side, you take your other arm, and you're just kind of pushing it down to just force that arc of motion. And by doing that multiple times a day, kind of really working on that, it helps those overhead athletes keep that motion. And it's kind of funny when you see somebody come in this time of year, I see an outside hitter, it's like, I can't hit, I can't do anything. 2 weeks later, after just doing a simple stretch, they come in like, this feels like in your shoulder. So that's really big, and that's also big in baseball. And then just doing the strengthening exercises, those programs I was talking about do a lot of kind of rotator cuff. So football athletes especially, you do bench press, you do incline press, you're doing squats, you're doing heavy stuff. What they don't enjoy doing is taking a band that's 5-10 pounds and working on doing rotation, keeping the rotator cuff strong. Because most of the lifts you're doing at the gym are great for the big muscles, but you're not really doing a lot to isolate the muscles of the rotator cuff. And so those programs have some of the band work that works on that, which is why you see a lot of the baseball players doing that, because that's kind of become more a part of their just culture of, okay, we need to warm up, we need to actually do these exercises. The other ones with the shoulder is kind of a unique joint in that it's not just the ball and socket. You have your shoulder blade, the scapula, kind of the big muscle, or all the muscles attaching to that big bone. And it doesn't really have an attachment to anything. It just kind of floats in the air, and the only thing holding it there are all the muscles. And in the United States, and even as I'm doing this interview, I kind of realize like we have a tendency to kind of hunch over. That's the normal thing.
As you look at me, I'm like,
everybody does it. And so the general posture of pretty much everybody in America is you just kind of hunch over, and that puts that scapula in a bad spot. So one of the things that we work a lot with athletes on is kind of scapular retraction, which is squeezing the shoulder blades back together. And then that does a few things, because most people in the U.S., your pec gets really tight, kind of this muscle up here. So most people, if you poke on your shoulder, you can find a spot in the front that's really sore. It's because you have a really tight pec and you're kind of bringing it down. So stretching that out.
I don't think I have any pecs.
And one of the exercises that is most fun to do with these really big linemen, linebackers, you have kids that can bench press more than I'll ever be able to squat. And you have them lay on a bench with just a 5-pound weight with their arms. You kind of make a W with your arms and you just bring them straight back. And it works the muscles around the scapula, the rhomboids for the nerds out there. And it helps stabilize that. You have these huge muscular guys that have these 5-pound weights that just cannot get it back there because they don't ever work on any of their scapular stabilization. And it's impressive. Whenever you get these guys stronger, you get their scapula stabilized, their bench press, their explosive strength goes way up, because when you're putting that shoulder in the right position, it allows you to push a lot harder. So it takes some buy-in to get the athletes like, what am I doing with these little foo-foo-y weights, like these bands? Like I'm a defensive lineman. I just want to hit somebody. This isn't working for me. And then you do those, you get that strength back, and you watch them go, and their bench press goes up 15, 20 pounds for the first time in a long time. And like, oh, okay, maybe he doesn't know what I'm talking about.
Better talk to your son.
He goes and gets full. He actually goes and get treated for full range of motion twice a week. So we're already bought into that.
It's the sports performance has come a long way from the old days where it's just like, yeah, it'll be fine. So now a lot of the training staffs work on these things. Physical therapy is really good for some of the patients that are having a little bit more issues. I think just kind of the knowledge for a lot of the athletes of buying into it has changed a lot.
Yeah, I actually, so I found out a lot of the things you're talking about, I found out they're due to an injury. My son had a foot injury, a fractured foot, and after the fractured foot led to other things, and having to go through the rehab process, that's when we learned that at an early age that he didn't have full range of motion in a lot of his joints. And just once we learned that, through talking to United Regionals, different things, it just was like, just make it a way of life. Even when he's better, just make it a way of life. If you make it a way of life, the outcome outweighs the negative. It kind of helps prevent other injuries and things like that. So it's very true. I've noticed, like you were saying, that the collegiate level, I've seen here in the Wichita County area, if you go to a lot of the weight rooms, I have seen a lot of the schools getting the bands and different things. And I mean, you're starting to see a big difference, I feel like, in the kids in this community, because I just believe everybody's bought into, hey, you don't have to lift the gym. If we can learn to do things the right way, it translates a little bit better on the field. So I'm definitely seeing that. Some of your kids that's not even the strongest kids when you're playing in the game, they seem like the strongest because they have the range of motion that you're talking about in those, especially in the upper body areas.
And we kind of talked about injury prevention. One of the things is, I think a lot of athletes, especially linemen, a lot of your strength, you're thinking like, oh, it's the push. Same thing for pitchers. Like, I need a strong upper body. Most of the strength that you come for almost everything in the shoulder, it's the entire, what we call the kinetic chain, meaning that your arm strength is connected to your core, which is connected to your leg strength. So we see it a lot at Vanderbilt. They did a lot of research looking at collegiate pitchers and just very small things. So if they had quad weakness, how does that affect their throwing? And you don't really think about it, but whenever that chain is interrupted or people with weak cores, it drastically affects their control, their strength, and same thing for football players. It's not just upper body or lower body. It's also having that core strength to connect the two. Like you mentioned, the range of motion makes a big difference.
So the next question I have for you is, of course, let's say Joe Black got injured. He has an injury to his shoulder. How does the process look like navigating and helping, the process of helping the kid? And I'll let you pick whatever injury. We'll just name any shoulder injury. Just kind of walk us through what the process looked like in navigating and getting that kid back to being to the level where they can play.
All right, so most of the times, whether it's practice, scrimmage, or anything other than a varsity game, it's usually the training staff that's there that's seeing the kid and working them up. Obviously, on Friday nights for varsity, a lot of the teams, I work with Memorial and Legacy High School, but we have medical staff at kind of different ones. So Friday nights, varsity games, there's usually a physician there. But the way I always approach it is I kind of let the training staff do their initial evaluation, kind of do their on-field things. And I trust their judgment. They do a good job of, all right, we need you to see the doc, or all right, this is just kind of, you got rolled up on, it's just a little sprain. So whenever I see them, it's usually just kind of a test of what's the range of motion, what's the strength, what sort of pain are they having. The sideline decision for a lot of injuries, especially lower body, but even shoulder, is kind of how well can they move it and how much strength do they have. So you mentioned shoulder, and an easier one's like the ankle, of do you decide to let a kid play or not. And my general rule, and I think what a lot of sports physicians do, is when it's strong enough that you can protect yourself and not injure yourself, I'm okay with you going back in. A little bit of soreness, I'm okay with, but if it's at a point where it affects the way that you're coming out of your stance, if it affects the way that you're going up to catch a ball, if it's going to change the way that you play, then I don't want them to go in. So the same thing for shoulders. If somebody has an issue where it's like, yeah, it feels great, but they can't bring their arm up, they're not going to really be able to protect themselves. So for those kids, they can't go back in. We do have a really nice setup where at our clinic we have the express clinic. So you don't have to have an appointment. You can just kind of show up same day. So it's been really nice for the kids that are playing middle school JV, or they get hurt in a practice at, say, like noon on a Wednesday. It's really easy for them to be able to come to the express clinic and be able to get in and be seen quickly. Kind of in that regard, kind of acts as an urgent care. And it's nice for orthopedic injuries, because if you go to the ER, you might sit there for a few hours and then they'll get an x-ray, and their goal is to make sure it's not an emergency. And they'll say, all right, well, your knee x-rays look fine. Maybe it's an ACL, but you need to go see an orthopedist. By going through the express clinic, they kind of save that step of, you're already there. They get the x-ray if it looks normal, but they're worried about having an ACL. They're able to get the MRI there. It just kind of speeds the process up, makes it a little bit easier. I've worked in a few different systems, and one thing that United Regional has done really, really well is patient access, and especially athlete access. So from the time that they need to get seen to the time that they get seen has been extremely efficient. Our imaging, same way. I've worked at some places where it's kind of tough to get an MRI quickly. Our athletes have been able to get in and get those done quickly. So we have an answer of, does it need surgery, or is this something we can rehab and get them on the road sooner, and not just sitting around for a week or two, just waiting to see what happens. And then once we see them in clinic, we kind of, based on what the injury is, kind of go that route. Thankfully, for young athletes, most things tend to be non-operatively treated. I'm a surgeon. I love operating, but my preference, especially for young athletes, is if we can avoid surgery, that's always the goal.
Yes, sir.
Yeah.
So I know you talked about the Express. That's one thing that I'm excited about that they do have. I hear nothing but good things about parents be like, my kid was hurt. I didn't have to go to the ER, because that used to be all you go to ER. And like you said, you sit there and all they tell you is, hey, you got to go see it. Or I just wasted an hour or two. So it's one of those things where they're going, and I think it's building trust, I believe. So I believe parents are willing now to go use the Express. They know now it also helps us as parents back up what the trainers have already told us, because a lot of times the trainers will tell you one thing and you be like, oh, they don't know what they're talking about. I don't know why people do that with the trainers, but they do. But the trainer be like, hey, go over here to the Express, we can get you in quick. And then you go and get the answer, and then you kind of looking like, I guess our trainers did kind of know what they were talking about. Because most of the time, the trainers are spot on. I mean, they do a good job, like you were saying. So I plug to the Ortho Express here in town. I mean, if you haven't been there, it's a place to go to. Beat the line at the ER. Just go straight there, especially if it's a sports injury. Just go straight there.
Yeah, that Orthopedic Express is open Monday through Thursday, 8 to 5, and then Fridays just 8 to noon. But yeah, like both these guys mentioned, I mean, it's growing. A lot of people, I can constantly hear about stories of friends taking their kids, and so that's a great place to go and get in and out and kind of get a head start on your recovery if they need that.
It's been well designed here. I've worked at places where physicians are all kind of separate in these little pods. The way that United Regional is set up, to where whenever a kid comes in, and there's always, I think, some concern with parents like, oh, I brought them in and I saw a nurse practitioner or a PA. I wanted to see a surgeon. We have really, really good NPs and PAs there that I trust, and I've seen their work and their ability to diagnose. But the thing that I think sometimes they don't see is there's always a physician sitting back there. So I'm there 2 days a week. Dr. Sheen's there 2 days a week. Dr. Hoffman, you have Dr. Langston, who's our non-op sports. So it's not just kind of this standalone, like, well, they're making all the decisions on their own. It's one thing that I've really liked about the physician and provider group here is there's a lot of, hey, look at this MRI. What do you think? This is what I see. A lot of that camaraderie that really helps, and it helps the patient out a lot. So that's something that a lot of patients don't see behind the scenes, because we're back there looking at the MRIs or the x-rays together, kind of talking through it. Like I said, it's more of an art of medicine. This is what this patient has. What's the best way to get them back, and to kind of get different mindsets for that, because everybody approaches it a little differently.
So I had a quick question about the sorry. So we mentioned earlier about the dislocation of the shoulder. This kind of going back to injuries, but is there, like, because I've always heard, and I've even witnessed this, like there's a dislocation that's like bad, that has an extended period of recovery time, and then there's a dislocation that can basically just be popped right back in and ready to go. Because I had a friend, we were playing a kickball game, and he rolled over and he got up, and I mean, his shoulder was out. I mean, it was like hanging. He was freaking out. I was freaking out. It was just real funny. We got the x-rays. The x-rays were, I mean, it was completely out of the socket, and then we were talking about, well, they can't get it back in. They're going to have to put you to sleep, and you're going to have to get it, reposition. He was like, and he popped it right back in. He was like, no, I'm good. Let's go. So is there any, probably ligament tears and stuff like that, or can you just, for me, I guess, describe the difference between those two? So
with shoulder dislocations, it's definitely kind of I would say a controversial and constantly changing thing. The classic way of looking at a shoulder dislocation is, first off, the main one that you get is kind of the athlete that falls on their shoulder back like this, or you'll see it in throwers where their arm gets caught and brought back like that. Most of the ones that we see are anterior dislocations, meaning the ball comes out the front because the arm goes back behind them. Whenever that shoulder dislocates and the ball goes out of the socket, it usually is able to be reduced either if it's at a game by the training staff or by the physician that's there, or in the ER. The debate is always, you have somebody that dislocated for the first time, what do you do with them afterwards? I think more classic teaching has been, if it's their first time dislocating, you're not super aggressive with an MRI or anything. You try to rehab, try to get their strength, their motion back, and kind of like we talked about some of the other injuries, when they have their full motion back, when they have their strength is kind of 80-90% of the other side, they're able to go back. And there's still, I think, a lot of benefit to that. And for some athletes, I'll do that. There is kind of some research out of Mayo Clinic in Arizona where they've started being a little bit more aggressive, where we kind of pinpoint, and we know certain athletes are higher risk. So collision athletes, so football players, hockey players, people that are going to get hit, if they've had a dislocation and they're still kind of under the age of 25, so the high school collegiate players, and they're going to continue playing in a position that puts them at risk, there is some debate of this redislocation rate's over 50%. Should we be more aggressive and go after it and start treating it sooner? it's kind of, I treat it on a patient by patient basis. And I have that discussion with them of there's not a right or wrong answer. You can find a surgeon that would say, absolutely not. We're not going to MRI this. We're not going to ever talk surgery until you dislocate a second time. You'll find some that are a little bit more aggressive. My general view is if they dislocated once and it was traumatic, meaning they got hit, and it takes a little bit of force to get it back in, which the kind of joke in orthopedics is easy in, easy out. So if it just falls right back into place, the likelihood of it just falling right back out is pretty high. So you actually want it to be a little bit tough to get in there. And the concern and what we talk about with surgery is whenever it dislocates, it usually tears that labrum, that little piece of tissue that makes the ball deeper. And so when that tears, it allows the shoulder to be unstable. It's nearly impossible to dislocate and not injure that in some way. Sometimes it's a little small tear. Sometimes you just rip the entire labrum off. So my usual approach with it is if they have their first time dislocating, try to do some rehab, get their strength, get the range of motion back, see how they're doing. I'll have that discussion about, hey, if you're a football player, you're a hockey player, you've got a decent chance that this comes back out. But I still, even just my personal opinion, is it's tough to really justify doing surgery on somebody that's only happened one time, and you're doing surgery for what could happen. The downside of that is if you dislocate again, every time you dislocate, you can hurt the labrum, and the bone pops back in, it kind of leaves a little dent in the bone. So that's really the argument for them. If they dislocate a second time, or if they start having atraumatic dislocations, and usually the stories that I hear from kids are, yeah, I dislocated it 4 or 5 days ago, I was rehabbing, I was doing okay, and I fell asleep, and I rolled over, and it popped out while I was asleep. That's whenever we talk about getting the MRI. Same thing for just kind of anything where it's like, oh yeah, I was at school, I went to pick up a backpack, or I went to grab the door, and it just popped right out. That's whenever I'm a little bit more aggressive at saying, right, we need an MRI and talk about treatment. And it's really every patient's different and kind of what they're trying to get back to, what their expectations are. Everybody's a little bit different. So that's a very patient-specific. And I'm really big on letting them kind of understand what's going on and letting them kind of dictate their own care, because at the end of the day, it's their shoulder, not mine. I just want them to know kind of the risks and benefits of each.
For sure, for sure. So we saw, or you talked about common injuries, injury prevention, navigating through the shoulder injury. Is there anything else that you want to talk about while you're here?
Really, that's kind of the main things. I think whenever it comes to shoulder, you kind of the prevention, I think, is what a lot of coaches, kids, parents want to know of. How do we prevent this? And there's some really good resources online for that. That also when I talked about, or you can just do shoulder prehab. Just Google that, and then it's mostly just kind of strengthening of the scapula, things like that, and really working on the range of motion. I think that's kind of the best thing to decrease the odds that you're seeing me. And that's not just for athletes, that's for the coaches and the parents too. I see a lot of patients in their 30s, 40s, 50s, 60s that a lot of it is treatable with therapy. So that's a big thing.
All right. Well, if you don't have anything else, I guess we'll wrap this up. And we appreciate, like I said, we appreciate you coming out and giving us some information. We appreciate you talking sports. We can tell you're a sports guy, which is pretty awesome. You have anything else, though?
No, sir.
You're good? You good?
Yes, sir.
You good, Doc?
Yes, sir. I'm good.
All right. Well, appreciate you.
Absolutely.
And we'll see you next time.
Excellent. Thank you, guys.
Take care. Yep.